Hello, I'm Nancy Berliner, Chief of Hematology at the Brigham and Women's Hospital and a Professor of Medicine at Harvard Medical School. And I'm going to speak to you today about leukocytosis and leukopenia. And I have no disclosures, and I will not be discussing any off-label investigational use of drugs. So I'm going to start with a case. This was a 43-year-old woman who was referred to my clinic for an elevated white blood cell count. She was previously healthy and was seen for a routine office visit and was noted to have a white count of 12,000 with a normal differential. And her PCP repeated the counts 3 weeks later, and they were unchanged, and her hematocrit and platelet count were completely normal. So when I talk about the differential diagnosis of leukocytosis, I always start with secondary illnesses because most of the time when you see a patient with an elevated white count, it's secondary to something else and is not a primary hematologic problem. Most common causes, as you all know from the hospital, of an elevated white count is infection. And this can occur in two ways. It can occur acutely by demargination of white cells. 40% of white blood cells are stuck to the vessel wall in small vessels and in the spleen. And acute stress can strip them off the wall, and you can immediately double your white count without releasing any new white blood cells from the bone marrow. When you have a slightly more prolonged exposure, then you may release storage pool neutrophils, since 75% of the neutrophil mass is actually in the storage pool in the bone marrow. They're mature neutrophils and bands that live and die in the bone marrow. More chronically, that requires an increase in neutrophil production. Can also raise your white count in response to stress, or can be induced by certain drugs. Chronic inflammation, because the spleen is a major source of margination of white cells. Patients post-splenectomy tend to have an elevated white count. And also then you can have it reflect non-hematologic malignancy or hematologic malignancy in the bone marrow. And only if you've ruled these out do you then find that you are dealing with primary hematologic disease like chronic myeloid leukemia or another myeloproliferative neoplasm. So neutrophilia is usually reactive and indicative of a normal functioning bone marrow. So you usually don't need to do a bone marrow evaluation. So the way I work these up, you repeat the white count to rule out either a factitious elevation or an artifact or some transient thing that makes the white count go away. So the PCP did the right thing to bring the patient back 3 weeks later and repeat it. You can evaluate for acute and chronic infection or inflammation. We used to do the LAP score, the leukocyte alkaline phosphatase score. This is almost never available anymore. But you may see it referred to in textbooks. It is an extremely limited value, since the only purpose of the LAP score was that in patients with chronic myeloid leukemia, the score was usually 0. And the normal LAP score has a very, very wide range of something like 2 to 200, which is done by scoring the amount of LAP you see in the white cells. But with the advent of BCR-ABL testing, fluorescence in situ hybridization for BCR-ABL is much more efficient and accurate in diagnosing CML, and we don't get that test anymore. And the only time to do a bone marrow exam in the setting of leukocytosis of this sort is usually to rule out granulomatous disease or fungus. So if you feel compelled to do a marrow, you should make sure it's cultured for those things. So just to finish with this young woman, this young woman had absolutely no underlying disease. She had no evidence of any inflammatory disease or infection. And so whenever I have a patient referred for white count, no matter how unlikely I think it is, I always check a BCR-ABL, because it is the only thing that can have a major impact on the patient. And much to our surprise, this patient was actually BCR-ABL positive and went on to get treated for chronic myeloid leukemia. This is a different elevated white count, another case. This is a 1-month-old boy who presented with an elevated white count, who had delayed umbilical cord separation, high-grade fever, methicillin-resistant Staph aureus infection, and a white blood cell count of actually 90,000. He had a history of poorly healing skin lesions, otitis, and failure to thrive, and he had a poor response to antibiotics. And as you may guess, as an adult hematologist, this was not one of my patients, and this was actually drawn from a published case of a baby with leukocyte adhesion deficiency. So when you have primary hematologic disease in children, there are hereditary neutrophilias, just like there are hereditary neutropenias that are usually of no significance. But the things that can give you a very high white count in infants of this sort are Down syndrome is associated with a transient myeloproliferative disease that can be, but is not always, a precursor to GATA1 positive M7 leukemia. But in this case, this is a case of leukocyte adhesion deficiency. So what is leukocyte adhesion deficiency? It is a failure of, as the name suggests, adhesion of neutrophils to the endothelial surface, where they then can diapedese into tissues and deal with infection. And it's caused by two or three different defects. One, the most common, is a defective integrin receptor common beta chain. It's called leukocyte adhesion deficiency 1. This leads to the loss of expression of LFA1 and the C3b receptor, the complement receptor. So in addition to an inability to adhere to the receptor on the vessel wall, it also impairs the ability to ingest and kill microbes opsonized by C3b. It can also arise more infrequently, as in LAD2, by an abnormality of selectin glycosylation, because that is the other receptor that mediates leukocyte adhesion. And so you get an elevated white count, but the white cells are inefficient and ineffective because they cannot adhere properly and do not properly kill bacteria. So clinical manifestations of leukocyte adhesion deficiency include a very elevated white count, recurrent infections. Almost every neutrophil disorder in babies is considered, and even in adults, is associated with recurrent infections, mucocutaneous abscesses, and gingivitis. Many of these patients die before the age of 2, and the treatment of choice is actually a stem cell transplant. G-CSF has been tried experimentally because G-CSF receptors are expressed on all stages of neutrophil differentiation, and they can improve neutrophil function, but it is not particularly effective. So now I'll turn to neutropenia, which is a much more important or frequent clinical problem that you may see. If you look in the textbook, they will tell you that a normal neutrophil count is greater than 1,500, although for reasons that I don't understand, many labs report that the normal lower limit of normal is slightly higher. If you have a neutrophil count between 1,000 or 1,500, that is often referred to as perhaps normal and is not associated with any increased infection. With a neutrophil count of 500 to 1,000, you may see some increased risk of infection, but fevers can be managed as an outpatient, and usually the increased risk is not very great. So what people hang their hats on is when you have a neutrophil count of less than 500, as a significant risk of infection. Fevers are usually managed with admission to the hospital for IV antibiotics. And classically, we warn people that with a very low neutrophil count, you may not have the usual signs of infection to show you where the infection is coming from, because neutrophils are required to make pus. In fact, in patients, if you see a lot of patients with neutropenia, as I do, the significant risk of infection in patients with acute neutropenia with a neutrophil count of less than 500 is usually related to patients who are getting chemotherapy, who have a white count of 500 on its way down to 0. And this is associated with all the other effects of chemotherapy, the gut mucosa, and those patients can have transitive bacteria and are more likely to get infected. Most patients with chronic neutropenia don't get into trouble unless the count is less than 200. And in fact, in patients who have been treated with chemotherapy who come in with neutrophil counts between 200 and 500, I always tell the house staff that they should look very carefully for a source of infection, because those patients usually don't have spontaneous fever and neutropenia, but in fact, usually are the ones that you may find a perirectal abscess, or you may find cholecystitis, or some other reason for them to have become febrile. I have been struck by the fact that in patients with chronic neutropenia, patients frequently have little or no manifestations of neutropenia despite having counts as low as 50 to 100. And although some of these patients have infections and require cytokine support, many of them do just fine with no intervention at all. So the differential diagnosis of neutropenia, there are many forms of congenital neutropenia. The most important one in everyday practice is to recognize benign neutropenia or constitutional or ethnic neutropenia. There are certain ethnic groups that have lower normal neutrophil counts, and most of these are in the areas where it is associated with the Duffy antigen, which is the receptor for malaria. So it's found in malaria belts. It's found in 90% of African populations, and African American populations are in fact Duffy negative, and neutropenia is quite common in them. The link between the Duffy antigen receptor complex and neutropenia is not understood, but it's clear that in those populations, including African populations, many Arab populations, and from close to the Mediterranean, which is also a malarial belt region, and in many Sephardic Jews and many other populations, will have a normal neutrophil count that can be as low as 800 to 1200. There are also benign neutropenias that are familial, and nobody knows what causes those. So that needs to be distinguished from the more severe disorders, severe congenital neutropenia, which I'll discuss in some detail, cyclic neutropenia, and then other rare immunologic disorders of childhood that are associated with neutropenia. So this is a useful table of all of the things which we know of that can cause congenital neutropenia, including the ethnic neutropenia, which I already mentioned, benign familial neutropenia, and then the severe congenital neutropenias, which, as you can see, are quite diverse and caused by many errors, and cyclic neutropenia, which I will also discuss. And then I won't go into detail, but you'll note that there are a whole host of immunodeficiency syndromes that can also be associated with neutropenia. So severe congenital neutropenia, or congenital agranulocytosis, is a rare disease. Despite being rare, it is genetically quite diverse. Can be associated with autosomal dominant, autosomal recessive, and sporadic inheritance. And it was originally a disease of infancy. It was associated with very severe infections, and before the advent of treatment with G-CSF, it was universally fatal at a young age. Now that G-CSF is readily available and has transformed the survival of this disease, and most patients survive to adulthood. And the downside of having successfully treated this is it's become clear that over time there is a high incidence, as high as 30% over 10 years, of evolution to myelodysplastic syndrome and AML in patients with SCN. So there are two major forms of SCN that account for probably about 75% of all cases. Over half are autosomal dominant and have been linked to mutations in the neutrophil elastase gene, used to be called ELA2 and is now called ELANE. And it is clear that this is not a reflection of the function of the enzyme, but the fact that it is a highly expressed enzyme. It's one of the major proteins in the primary granule of the neutrophil. And it's become clear that mutant elastase accumulates in the cytoplasm of the cell and activates the unfolded protein response, which is a cellular stress response that, when unsuccessful, as it is in this case, results in apoptosis. It was originally thought that the autosomal dominant form of SEN would be related to mutations in the GCSF gene or the GCSF receptor, which turned out not to be the case. However, it was noted that when patients developed AML, a large majority of them get AML in association with an acquired truncation mutation of the GCSF receptor. And there's considerable controversy of how this contributes to the AML, although it is probably not specifically caused by GCSF. It is a mutation that increases the sensitivity of GCSF and shifts the dose response curve, such that it is probably playing a role, at least in clonal dominance of the mutant clone. But it turns out that most of the AMLs have many of the same mutations that you see in de novo AML, not in this setting. The second most common cause of severe congenital neutropenia is the original Costman syndrome, which was described 50 years ago by a medical school student at the Karolinska Institute. And it is a syndrome that is autosomal recessive and is linked to mutations in a completely different gene from the autosomal dominant form. It's linked to mutations in HAX1, which is a mitochondrial protein associated with signal transduction. And disruption of HAX1 and myeloid cells destabilizes the mitochondrial membrane, causes release of caspases into the cytoplasm, and also leads to the final common pathway of apoptosis. What is striking is that HAX1 is a ubiquitously expressed protein, and one of the surprising things is that the overwhelmingly most common manifestation of these mutations is severe congenital neutropenia, although it is also associated not unexpectedly with other congenital abnormalities as well. Autosomal recessive SEN is also associated with AML, which strengthens the connection to the use of high doses of GCSF. And then there's a fascinating disorder called cyclic neutropenia, which is also dominantly inherited. It's associated with a cycle of neutropenia that is can range from 15 to 35 days, but in any individual tends to be completely regular with a fixed interval. And the marrow during neutropenia shows a myelocyte arrest. It's usually benign, but patients with severe infections may require GCSF. What's striking is that this is clearly a cell autonomous disease, because there's a case of a patient who had cyclic neutropenia, who developed AML, whose brother developed AML and was a donor for that brother, and when the brother engrafted, also had cyclic neutropenia. The other fascinating thing is that, like autosomal dominant SCN, cyclic neutropenia has been linked to the mutations in exactly the same enzyme that is mutated in autosomal dominant severe congenital neutropenia and is found in essentially 100% of cyclic neutropenia. It is not associated with an increased risk of AML, and it is not at all clear which genes in the genetic background of the individual predisposes to cyclic neutropenia rather than severe congenital neutropenia. In fact, it was originally thought that this might be associated with different mutations in the gene, but it turns out that it is obviously related to the genetic background on which this mutation arises. There was a fascinating experiment of nature where there was a man who was a sperm donor who, unbeknownst to anyone, was chimeric for an elastase mutation. And he fathered 8 children, 5 of whom inherited the mutant elastase gene, 4 of whom had severe congenital neutropenia, and 1 of whom had cyclic neutropenia. When they subsequently went back and examined him, it turned out that all of his white cells arose from the wild type elastase, but all of his other tissues showed both genes. I'll move on now to autoimmune neutropenia, which is something that we are asked to see quite frequently. And this just shows you that there are two peaks or two patterns of inheritance. We have primary autoimmune neutropenia, which is seen primarily in children. And this is the one that is associated with antibodies against common neutrophil antigens and is often seen very shortly after birth. And the vast majority of these patients are diagnosed at less than 3 years old. And then there is secondary autoimmune neutropenia, which is seen primarily in adults. As you can see, it's very rare in children, associated with autoimmune disease, with large granular lymphocyte leukemia, and associated quite rarely, although I've never seen it, by report with leukemia and lymphoma. So primary AIN is a disease of childhood that's caused by anti-neutrophil antibodies. The average age of onset is 6 to 12 months. It's associated with moderate to severe neutropenia, and 95% of these children will undergo spontaneous remission over the course of 2 years. Treatment is to give prophylactic antibiotics, and only with severe and recurrent infections do these patients require G-CSF. The other 5% of these children are quite poorly understood, but there is evidence that they tend to have a pattern more like secondary autoimmune neutropenia, as seen in adults, and have a higher incidence of underlying autoimmune disease. So secondary neutropenia in association with autoimmune disease is extremely common, and I'm sure all of you have seen it many times. Autoimmune neutropenia occurs in association with lupus in approximately 50% of patients, tends to be a marker of disease activity, and has very little impact actually on the course of the disease. And when patients with SLE and mild neutropenia have infectious complications, it almost always correlates better with immunosuppressive therapy than with the height of the neutrophil count. And because the white count falls when they have a flare, it can be difficult to sort that out, but they tend to have infectious complications that are non-bacterial, which is of course the classic finding with neutropenia. The pathophysiology is very complex. There are some questions as to whether they have neutrophil-specific antibodies, whether it's mediated by immune complex destruction. There also is evidence for increased apoptosis of neutrophils and decreased neutrophil marrow production. There is also neutropenia can be seen in association with rheumatoid arthritis. The sort of classic picture of neutropenia in RA is so-called Felty syndrome, which is typically seen in patients with long-standing RA and multiple end organ manifestations of the disease, such as pulmonary fibrosis, vasculitis, rheumatoid nodules, and is not seen very often anymore because there are better disease-modifying agents so that patients don't tend to have such long-standing active disease. It's classically associated with splenomegaly, and it's quite a morbid disease, and the morbidity and mortality from bacterial infection can be quite high. There is also LGL-associated neutropenia, both in association with Felty syndrome and with RA and outside of RA. Large granular lymphocyte neutropenia shares many features with Felty syndrome in the setting of RA. Classically, it was thought to be a monoclonal neoplastic disorder, while Felty's was traditionally felt to be polyclonal. But as we've become better and better at finding small populations of clonal lymphocytes, this has turned out not to be a very good distinction. And in fact, the observation that in the setting of RA, 90% of patients have are positive for HLA-DR4. This suggests that they are a spectrum of the same disease. So I'm often sent patients who have had anti-neutrophil antibody tests. And so I wanted to mention them because there's always some question about the importance of these results. Now, we know that when we have a patient with autoimmune hemolytic anemia, the Coombs test is really the gold standard test for establishing that there are antibodies directed against red cells. So it's often confusing to people to understand why this is not as reliable in looking at neutrophil antibody tests and in fact also looking at platelet antibodies. And the problem is that unlike red cells, white cells and platelets have abundant FC receptors. And so anybody who has high levels of circulating antibody or circulating immune complexes will have a false positive anti-neutrophil antibody test because of passive adhesion through the FC receptors to those. In addition, neutrophils are very finicky cells, and the tests for neutrophil antibodies are based on spontaneous fluorescence or aggregation or lysis of neutrophils, all of which neutrophils are perfectly happy to do in a test tube without any instigation at all. And so you have to have a lab that's highly skilled in being able to tell whether the neutrophils are undergoing spontaneous fluorescence, aggregation, or lysis, or whether this is in fact antibody related. In addition, the effect on outcome remains undefined. There's no gold standard. It is not a gold standard. Non-neutropenic populations often have detectable antibodies, and in fact, a large study of pregnant individuals showed that almost 5% of individuals given antibody tests for neutrophil antibodies were positive, and this did not correlate with any neutropenia either in the mothers or in the babies. And there's a very poor correlation between the level of the antibody and the degree of neutropenia. In children, the test may be helpful in primary autoimmune neutropenia because, as I said, those are well-defined antibodies directed at portions of the FC receptor complex. But in adults, it is much less reliable. So the question is, when do I check anti-neutrophil antibodies in adults with neutropenia? And the answer is, I don't. Okay, I'm going to have one more brief case presentation. This is a 65-year-old man with sore throat and fever who comes in. He has a history of chronic CHF and has started on several cardiac drugs a couple of months earlier. He had a hemoglobin of 12 and a platelet count of 190,000. His white count was 0.7 and his absolute neutrophil count was 50. So this, of course, is a case of drug-induced neutropenia. I've listed here the most common drugs that have been associated with drug-induced neutropenia or agranulocytosis, but there are a whole host of, there's almost no drug that has not been associated in some patient with decreased neutrophil count. So the important thing in drug-induced neutropenia is to recognize that there are two different kinds of drug-induced neutropenia. Many drugs, including many neurotropic drugs, will cause a slight decrease in the white count. That is a dose-related response. Many antibiotics, including chloramphenicol, which also causes idiosyncratic neutropenia, cause dose-related reductions in the white blood cell count. The important reason for recognizing that is they tend to be stable, and if the patient really needs the drugs, there is no indication for stopping the drug for drug-induced neutropenia associated with a dose-related suppression of the white count. That needs to be distinguished from the idiosyncratic drug reaction, which leads to profound neutropenia or agranulocytosis. And although the pathogenesis is poorly understood because these are rare, sporadic, and transient, and so it's difficult to get a large study together, it is known and very clear that if you have idiosyncratic reaction, you can never take the drug again. There's evidence that there are anti-neutrophil antibodies. They can be autoantibodies. They can be drug-dependent antibodies that then are associated with other antibodies. Sometimes they bind complement. Those are the, and in Graves' disease specifically, where many of the antibodies are in response to anti-thyroid medication, it's thought that the antibodies cross-react with TSH. Unlike in chronic neutropenia, where I said patients are usually very happy to live with a white count that can be as low as 50 to 100, drug-induced neutropenia is associated with significant morbidity and a mortality as high as 10% in some studies. And then my final case of neutropenia is a 31-year-old woman who was referred to neutropenia to my clinic, who I followed for many years. At age 16, she was seen multiple times in the emergency room with abdominal pain, fever, and vomiting, and after multiple episodes was diagnosed as having appendicitis. Postoperatively, her white count fell to 2,000 and then on to an ANC of 500 that progressed, and the neutropenia has persisted ever since. When she was referred to me, the question was, 15 years later, why she had never recovered her white count after surgery. But in retrospect, when you talk to her, she'd had frequent upper respiratory illnesses as a child, including several episodes of pneumonia. And about a year before, her PCP had gotten nervous and begun her on weekly G-CSF. And on review of symptoms, everything was fine except that she had nausea and vomiting for 1 to 2 days every week after taking her G-CSF. So this is chronic idiopathic neutropenia and is one of the more frustrating diseases that we take care of, although patients do extremely well. These are patients who have normal marrow cytogenetics, have variably cellular marrow, no evidence of autoimmune disease, nutritional deficiency, or myelodysplasia. And this has a very benign clinical course, often diagnosed on routine blood cell tests in asymptomatic patients. And patients have a very variable need for cytokine support. And no one knows what causes this. It's probably a heterogeneous disorder. There's a group of patients that have been described with chronic idiopathic neutropenia from the island of Crete, which is entirely the work of 2 investigators. But these patients are not like the patient I described. These are patients who have a chronic neutrophil count of 1,000 to 1,200, and of course may very well have some form of ethnic neutropenia. This patient did wonderfully as soon as I stopped her G-CSF and told her to stop taking it, got rid of all of her symptoms. She actually had a palpable spleen that regressed after she stopped taking G-CSF, and she had no increased infections. So how do you work up the neutropenic patient? Obviously, you stop potentially offending drugs if the neutropenia is severe. Bone marrow aspiration and biopsy, I usually recommend patients at most have 1 bone marrow to make sure it's negative. Most of the patients that are referred to me have already had 4 or 5, so I very rarely marrow these patients. You can do serologic studies. I've already told you that I don't really believe in anti-neutrophil antibodies, and you can rule out primary malignancy. And therapeutically, aggressive treatment of infections. Immune neutropenia responds very well to steroids and IVIG. It can also, LGL-related neutropenias respond to low-dose methotrexate. They also respond to Cytoxan. And G-CSF is useful for almost all forms of neutropenia, and the real issue is what is the basis for using them. Obviously, in severe congenital neutropenia or cyclic neutropenia with frequent infections, you give G-CSF. But it can also be used in anyone who is severely neutropenic and is febrile and infected. And I actually think that it should be used in the treatment of drug-induced neutropenia because of the high mortality rate. So as I've mentioned, responses to G-CSF has been seen in neonatal primary and secondary immune neutropenia, as well as the non-immune congenital neutropenia that we see in adults. It's frequently unnecessary and can be reserved for recurrent or serious infections. And you should remember that if you use it in a patient with Felty syndrome, it may cause a flare of the joint disease because, as I mentioned, G-CSF receptors are expressed on mature neutrophils and increase their function. It shortens the time to neutrophil recovery in drug-induced neutropenia or agranulocytosis. Again, as I mentioned, it's very difficult to get evidence-based data because it's a rare disease, and the only randomized trial that was done had only 24 patients and used a subtherapeutic dose of G-CSF. But as I've mentioned, in the face of 10% mortality, the safety and efficacy of G-CSF, I think, justify its use. So the take-home message is that leukocytosis is usually reactive and the sign of a healthy bone marrow responding to external signals. Peripheral smear and PCR findings can usually provide clues to the less common primary bone marrow disorders associated with elevated neutrophils. And as my case illustrates, you have to be careful not to miss CML. Neutropenia is more commonly a manifestation of a primary bone marrow problem, although autoimmune disease and sequestration both occur. And although rare, the study of congenital neutropenia has provided key insights into neutrophil biology and AML. And acquired chronic neutropenia is usually benign, although the pathophysiology is poorly understood. So I have a couple of questions. A patient with hyperthyroidism is started on propylthiouracil. 6 weeks later, she comes to the emergency room with a fever of 102 and a tonsillar egg state. CBC shows a white count of 1,500 with 5% neutrophils, a normal hemoglobin hematocrit, and platelet count. The PTU is discontinued, and appropriate therapy should include A, start the patient on amoxicillin and schedule her to return to clinic the following day for follow-up of her blood culture or throat culture. B, admit the patient to the hospital and begin broad-spectrum antibiotics and G-CSF. C, start the patient on amoxicillin and admit for observation. Or D, admit the patient to the hospital and begin on broad-spectrum antibiotics. So as I said at the very, quite late in the talk, this is a patient who I would admit to the hospital and begin broad-spectrum antibiotics and G-CSF. In the presence of a normal hematocrit and a platelet count, acute development of a very low neutrophil count is essentially always related either to a drug or a toxin. This is true even in the setting of HIV, where there are many possible etiologies for neutropenia. This patient's agranulocytosis is almost certainly induced by PTU, since it's one of the drugs most commonly associated with agranulocytosis. Her absolute neutrophil count is 75. She needs emergent treatment for her neutropenia with broad-spectrum antibiotics. The recovery of the white count can be speeded by G-CSF, and although no controlled trials have shown increased survival with G-CSF therapy, drug-induced neutropenia is associated with high mortality, and G-CSF, therefore, is something I recommend to reduce the time to neutrophil recovery. So the second question, a 19-year-old Nigerian woman has recently emigrated to the United States and has been accepted to college. She goes to have her pre-admission physical and complete her health forms at the University Health Services. A CBC reveals neutropenia, and her physician advises her to wait to move into a dorm until she has seen you for evaluation. She is healthy with no history of infections and has a completely negative past medical history. Her exam is normal. CBC shows a white blood cell count of 3,400 with 30% neutrophils, so she had an absolute neutrophil count of roughly 1,000. Her hematocrit is 41, and her platelets are 200,000. What should you advise her? A, she should have a bone marrow to rule out bone marrow process causing neutropenia. B, she should have serial blood counts to rule out cyclic neutropenia. C, she should move into the dorm without any further evaluation. And D, she should have chromosome analysis of her peripheral blood. And of course, the answer is C, she should move into the dorm without any further evaluation. The normal neutrophil count is partially determined by ethnic background. African males frequently have a neutrophil count of 1,000 to 1,500, and African women may have counts that are even lower. Many may actually have counts below 1,000. With a total neutrophil count of 1,100 and a normal hematocrit and platelet count and an unremarkable history and physical, the patient should be diagnosed with constitutional, or otherwise called ethnic, neutropenia. This requires no further evaluation, and the patient should be reassured that these counts are normal for her and present no undue risk, and she should matriculate in college as planned. And there are some references. Thank you.